Hey everybody, welcome with this last and third part of this advanced shoulder webinar series. But before we start with the third part, the dorsal and inferior part of the shoulder joint, first we need to finish the supraspinatus. Last week we could not discuss the pathology section, so that is what we're going to do first. I hope you could have studied the webinar recording and also the articles we sent you. And yeah, let's make a good learning experience of this third part. Feel free to leave your questions in the chat area. So whenever you have a question, type it in, and in the short Q&As in between the sections, then we'll answer them. And I'm still Mark Schmitz, founder and trainer at Sonoskills and working in the radiology department in the Laurentius Hospital in Roermond, the Netherlands, my hometown. And let's start with discussing the measurements of the supraspinatus. So looking at the supraspinatus, we can do this in two planes, of course, longitudinal plane and transverse plane. And on the left image, you can see the transducer placement. So it's roughly parallel to the spine of the scapula. And then in that case, you are longitudinal on the fiber orientation and on the internal aponeurosis of the supraspinatus. And this internal aponeurosis, you can see all these fibers inserting to this aponeurosis. This has well been documented by the author Kim, who made I think a PhD thesis in this topic, pination angles of the supraspinatus. And we know that the pination angles can change with sarcopenia, with fatty infiltration, with atrophy, with tearing and ruptures of the supraspinatus muscle or tendon complex. I don't do that much with pination angle measurements, so I'm not skilled enough in that. That's still for me to learn. But I do look at this image because what we want to see is nice crispy lines, the fibers, but also the internal aponeurosis. And this can help you in diagnosing only by looking at it. In general, if there is a fatty infiltration, which could be really interesting to know if the surgeon is considering a surgery in case of a supraspinatus cuff tear. This is the transducer, the transverse transducer placement, and then we can measure from the supraspinous fossa to the top of the supraspinatus tendon, and overlying we can see the trapezius muscle, but we measure until this point the epimysium of the supraspinatus. So this is the muscle thickness, and here you can see a table with some norm values. You can also do a cross-sectional area measurement. Think of track by trace. So in that case, with the cursor, you have to, or the trackball, you have to drag the mouse yourself and make the calipers. Or you can do a measurement with oval, but in many cases this is less accurate. But it is easier for estimation of supraspinatus cross-sectional area. We can also look at the acromiohumeral distance. That is the distance between the top of the acromion and then the distance towards the humerus. And in the literature, you can find many types of measurements. At the bottom of the slide, you can see the references. And to me, they are all a little bit vague and not really accurate, and there is very much room for interpretation. So I think that personally, I think that the reproducibility is a little bit lower. So how I do it, and I have to say this is the Schmitz measurement, so my own measurement. This is not the golden standard. and this has not been researched, I believe, but I draw a horizontal line between the biggest part of the bone, so that you follow as much as bone as you can of the humeral head and the glenoid or the greater tubercle, and then from this horizontal line I measure the top to the acromion. And I think this measurement I don't use for comparing with colleagues who send in other patients. So I think this is something I do. So in TUG, reliability is a little bit lower. But definitely if I measure with my patient group, and especially within a person, left-right comparison, this tells me a little bit, is there a cranial migration of the humeral head? Is this acromio-humeral distance smaller? Is the outlet for, or the inlet for the supraspinatus and subacromial subdotted bursa, is it big enough? And this really helps me in my clinical reasoning and decision-making. Looking at the sonopathology, of course, we always use the Sonoskills pathology checklist. Having this checklist, having multiple assessment points. First, analyzing the structure or the integrity of the pathology, and we look at shape, then echogenicity, the continuity of fibers. We do our Doppler measurements, and if possible, looking at a functional perspective. And if we did this, then we need to interrupt the pathology, double check it. So make sure you scan 2 planes and maybe left-right comparison. Measure, and of course, how clinical relevant are the changes. So you might have to do some additional testing to assess the clinical relevance. Looking at the ESSR consensus statement, we discussed this also in the previous 2 parts. Then we can see that rotator cuff as a general, we also showed this with the subscapularis. This is the same in this consensus statement for the supraspinatus and also later for the teres minor and infraspinatus. We know that bursitis, full thickness tears, the calcific tendinitis scores a 3, meaning the preferred imaging tool, MSK ultrasound being the preferred imaging tool to assess these pathologies. It's equal to other if partial tearing, and atrophy is a little bit less to scan with MSK ultrasound, so be careful with that. We can use with changes of the supraspinatus, there are several classification models, and this is one that is also being used in MRIs. Grade 0 is a normal tendon. Grade 1A, B, C is tendinopathy. So we have changes within the tendon structure, but no tearing. And 1A less than 25%, 1B 25 to 50%, and 1C 50% and more. And then we have grade 2, 3, and 4 being the tearing, partial tear, full thickness tear, partial width tear, and then the complete tear. So this is grading system you can use, and I also use in clinical practice. Not known in every profession, but I think I shared this article with you last week. It's this tendinopathy model of Jill Cook. It's quite old. It's already from 2008, but I think it's still really interesting. Looking at reactive tendinopathy, tendon disrepair, degenerative tendinopathy. So it's not so much quantification, what was done actually in the previous classification model. It's more looking at acute or quite young. It's about medium term and also long term, more degenerative. So this is more in time, and the previous classification was more quantification. So I think best to work with a certain hybrid model. And if you study this article of Jill Cook, which you got last week, then you also know that in these stages, reactive or in disrepair or in degenerative, guides you also in your clinical decision making. It's also important if looking at tendinopathies to grade the fibrillar disruption, and this is a little bit like the first grading system. I think actually that one is better than this one, but this is also one that is being used frequently. So you can choose many classifications. I think we should stop developing new classification systems, and it would be actually better to slowly go actually to only one, so that we start speaking the same language. And we can also grade the neovascularization, mild, moderate, severe, and extreme. And I think this is also a very useful classification for talking about, discussing, and quantifying neovascularization. Okay, so first let's look at the tendinopathy, grade 1, B, and C, or that was the quantification, or in time, reactive, disrepair, and degenerative. In this case, we can see that the shape especially of the right, this is right, this is the left one, and especially the right one, the thickness has changed, measuring from column anatomicum, anatomical neck, to top of the tendon. We can see that the echogenicity is not so homogeneous, so it's quite scattered, like hyperechoic, hypoechoic, maybe even some anechoic parts. But we still see that most fibers are intact. So this is a tendinopathy, and I think that this is a 1C. I would say a 1C a tendinopathy. It's more than 50% of the tendon. The whole tendon is involved, and I would say this is a tendon. A reactive tendon, so it's not in disrepair, but it's reactive. I mean, it is in disrepair. It's not degenerative. It's in disrepair. Looking at that was longitudinal. This is in transverse, and actually the same. In this case, the thickness on the left one is a little bit thicker. So it's a transverse tendon, and also it's not very equal in echogenicity. We don't see any tearing, so there is no partial or full thickness or complete tearing. So this is a clear tendinopathy. So we would like to have a nice even spread, if possible, of the echogenicity in the tendon. Looking at the calcification, I shared with you last week a white paper I wrote containing multiple sources, all discussing calcification. So if you haven't studied that, please do. I think it contains some interesting information. And we know that we can measure calcification with a lot of imaging modalities, but ultrasound scores a 3 in the ESSR consensus statement. It has many patient advantage, being more patient friendly. It's dynamic, it's real time. It can visualize the calcification perfectly, especially if we have a type 1 or 2 calcification. Talk about that in a minute. So please use as much ultrasound as you can to look at calcifications. So calcifications, the calcifying tendinopathy process has several stages. The pre-calcific stage, the calcific stage, and the repair stage. And in the first stage, the pre-calcific stage, changes are happening within the tendon, and it's mainly asymptomatic. And then you enter at one point the calcific stage, which has 3 subphases. And with formative phase, you are feeling a little bit mild pain. In the resting phase, the calcifications are being there is a deposit, it's clear, or it's nodular, and you feel moderate to severe pain. And in the resorptive phase, then you have also very severe pain, but this fades away after roughly 2 weeks. And then there is a repair stage, This may many months, and I would even say many years in some cases. And then in the end, a lot of calcifications that are actually self-limiting, and they are being absorbed with by the human body. So an ultrasound can play a role in looking at these calcifications, but is not so very suitable to differentiate in which phase a certain patient is. And I think that the second stage, the calcific stage, and these three phases in the calcific stage, they are most clinical relevant, but ultrasound can only look at it, but not differentiate. Why does it happen? Well, actually, there are a lot of hypotheses, and there's a lot of debate, and these are the most commonly known or commonly used hypothesis. It's mainly about vascular ischemia and or degenerative changes within a tendon and a certain level of tendon necrosis. So I would say that these are the most important hypotheses, but many do exist in the literature, and I don't know the golden answer. And the pain, they can be caused a certain chemical irritation or a certain pressure putting on some tissues, but also because you're not using the shoulder, then you have stiffening of the joint or weakening of certain muscles because of disuse, and this can produce secondary complaints. And we also know that these calcifications can migrate in the tendon, so they can start in the deeper tendon and they can migrate, and then at one point come in contact with the subacromial subdelta bursa and even penetrate in a bursa. And the calcifications, as you know, they are large, or some smaller ones, or very scattered, very a lot of small deposits, and it says few small deposits. It can be small, it can be few, but it can also be a lot of punctured deposits. So it has quite a various appearance. So they can produce a shade, a lot, or faint, or sometimes no. And if there is no shade, I will show an image of that, then you have to be careful, because you might miss them in your image, because the hyperechoic calcification blends into the hyperechoic tendon. So these are the three types of calcific or calcifications. Type 1, a lot of shade, so it's being produced. Type 2, we can see a little bit of shade, but these lines, they are still intact, although it has a certain degree of calcification on top of that. And type 3, it's going more towards the resorptive phase. We can see this calcification there, but producing no shade. And if inexperienced, this could lead to troubles, because you might miss it, or you might miss it. These calcifications can be more like a deposit, but sometimes even they can be like anthesophytes and certain insertions, or they can be like longitudinal tearing. You have this delaminization process, and a certain calcification can also happen between these two laminas of a tendon, and these can also be observed in the X-ray in this case. And please know that sometimes in longitudinal you can see them very well, and in transverse they might be very small. So really look well, toggle your transducer. Sometimes they might be highlighted or pop up when you toggle. In this case, this is a severe case of a calcific tendinopathy. We can see a lot of scattering of calcifications throughout the tendon, some being softer, type 3, some being harder, type 1. And in this case, with Doppler imaging, we can see a clear positive Doppler signal. Looking at the impingement, impingement can happen. This is a consequence, it's not a cause. So impingement is never the disease in itself. If you know that there is an impingement, you always have to look for the additional cause leading to this impingement. We could have primary or secondary impingement, and the primary one is really narrowing of the subacromial space. For example, the bursa or the supraspinatus has increased in thickness, or the bursa has increased in thickness, or the bone is actually thickened with calcification or osteophytes. And secondary, it's then the cause is somewhere else in the shoulder girdle, muscle weakness of, for example, the scapular muscles, or hypermobility of the glenohumeral capsule or joint. And then this might lead also to a impingement. So this article I also shared with you last week. Please read. And then especially the extrinsic mechanisms that are interesting to realize, because I think that in most people who are watching this webinar, you can influence these things, and that might help the patient in, this might prevent in developing a impingement. So looking at the acromial-humeral distance, and we can see that, sorry for that, we can look at the acromial-humeral distance, and we can see that the supraspinatus fits underneath the subacromial space. But in this case, we can see that the acromial-humeral distance is smaller than the tendon bursa itself. So this won't fit into this, this inlet, the subacromial space, and a friction is bound to happen. So you can see the tendon really hitting the acromion and then being pulled down with a friction, and sometimes it's even impossible. So it blocks, and the patient cannot go any higher with its with his or her abduction. And if we're scanning the shoulder dynamics with abduction, you can do this at the acromion level. In that case, we're assessing the posterior part of the supraspinatus. But if you want to see the anterior part of the supraspinatus, you can also scan the dynamic gliding of the supraspinatus in relation to the coracoacromial ligament, placing the transducer like that on the supraspinatus. So if you want to find it, place the transducer on top of the acromion, slide ventral, 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 ventral until you see no acromion anymore, and then you see actually this image. You can see the tendon and bursa, and if you ask a abduction with the patient, then you can see that this is the transverse coracoacromial ligament. That this mass wants to go there, and in this case, this is a problem because we can see clearly this filled bursa, and to my experience, measuring in the anterior supraspinatus tendon with the coracoacromial ligament gives you much more results than only measuring at acromion level. Although at acromial level, this you can see in all books, but the transverse tendon in relation to the longitudinal tendon, I actually rarely see in the literature. Tendon tearing can happen all around the supraspinatus tendon. We do have a zone which is particularly at risk, and this zone is actually around the anatomical neck, the column anatomicum. We know with loading distributions that this is the zone that is being loaded the most. When heat mapping, the darkest colors can be seen there. We also know that around this column anatomicum there is an avascular zone, which is a poor prognostic factor for healing and regeneration process of a tendon. So in this avascular zone near the column anatomicum, we can see that in many cases most tears do happen. The supraspinatus measurements they are, you need to learn it. And there is a certain learning curve to it. And we know that from this article that 0 to 50 times you start learning, and there is a lot of learning. And then 50 to 75, then you start accurately distinguishing a normal supraspinatus. And then the most learning happens between 75 and 100. And there's a certain plateau. And with 100 to 100 to 200, there is a refinement of your diagnostic accuracy. So let's say if we shoot for the best, because that's my philosophy, always aim for the best, you need to do 200 scans before you have very high diagnostic accuracy. So if you do only 2 per week, 2 shoulders, then it needs 50 weeks or you need actually 100 weeks to almost 2 years to get this diagnostic accuracy. If you see 20 shoulders a week, it only needs 10 weeks, 2.5 months. So this is all up to you. The more you scan, the better diagnostic accuracy you will have with this supraspinatus. So let's look at the signs of the of cuff tearing. Let me put the camera there. Yes, like this. We know that a biceps halo might be a indirect sign of a cuff tear. So if the tendon looks okay and there's no tenosynovitis, no Doppler activity within the tendon sheet, then we know that this is the deepest point of the capsule, and somewhere fluids, probably or most likely also cuff related, they sink to the deepest point, and then you can see this biceps halo. Cortical changes near the insertion. So if we have cortical changes, then we know, and especially around the anatomical neck and greater tubercle, we know that this correlates to a high degree with tendon tearing. Sometimes very subtle, sometimes also quite a lot. So yeah, please know that this is a strong correlation. The deltoid hernia sign, meaning that, let me go back to my drawing board. Yes, if there is a concavity of the tendon, so a convexity of the deltoid muscle, which is like hanging within this concavity of the tendon, this is called the deltoid hernia sign. And this is an important factor, that below this concavity, in the depth, there is a large tear and loss of intratendinous stability. The cartilage interface sign is this hyperechoic line, is typically related also to large cuff tearing. Compressibility in a tendon, for example, this is a tear, and if I press with my transducer, then can I compress the tendon? This should not be possible, but in some cases it is. And in this case, the tendon is not convex, but is flat, because there is still fluid within this tear. But if the fluid goes away in time, then you will see a concavity there, a collapse of the tendon. Fluid in the bursa can be a prognostic factor, and also when stressing the tendon, opening up of the side of tearing is really typical for cuff tearing. So let's look at these effusion signs. If we have fluids in the joint, 60% has a cuff tear, fluid in the bursa 70%, and if you have both in the joint and also in the bursa, 90% has a cuff tear. So if you have the transverse supraspinatus, and you can see on the humeral head, and you can see also the hyaline cartilage thickness increase, you also know that the fluid has been increased in the glenohumeral capsule. But also if you have this biceps halo, this is also glenohumeral joint fluid. So this can add to the double effusion sign. And greater tuberosity irregularity, 90% has a cuff tear. So this is a strong correlation. Partial tearing, we can have near the bursa, and this is called, the bursa is here, and this is called a partial tear bursal-sided. And in this case, this is a very clear case of a partial tear, which has like 50% of the tendon and it's very close to the bursa. These are easier to, and with higher accuracy to diagnose compared to a articular sided tear. So bursal sided tears are easier to diagnose and they have also a better prognostic outcome. And these are also examples of bursal tears. So the articular sided tear close to the bone, and we know that because the hyaline cartilage is anechoic, and we have an anechoic zone anyway there, and then also a tear. If the tear is small, it's very hard because anechoic hyaline cartilage, anechoic tearing might overlap. You might miss it. So yeah, look closely to this zone. And in this case, we can see that this might be anisotropy. You need to toggle and to heel to toe rock your transducer. But in this case, we know that it is a articular sided tear, longitudinal, so the length and the height. And here we can also see the width of the tear. Also a clear case of a partial articular sided tear near the anatomical neck. So we know that that partial thickness articular sided cuff tears, if they are involving the rotator cable, this is a bad thing. So this is a poor prognostic outcome, and this you should really write in your report because this is important knowledge for the surgeon. Yes, so I think that's clear. Looking at the full thickness tearing of the supraspinatus, and personally, I think that full thickness should be combined with partial width. So in one plane, you can see a full tear, but in the other plane, you can see still parts that are intact. Full thickness, partial width. If it's in both plane, it's detached, ruptured, torn, and in that case, we call it a complete tear. So full thickness, partial width, and most full thickness tears, they start or they occur in the zone that the transition between supraspinatus and infraspinatus. And this, if you want to know where can we find it, this is roughly 1.5 centimeters, 15 millimeters laterally to the biceps tendon. So this is a very common place for rupturing. And we can also see this in this article that the peak is roughly here, and you can see that's 15, 16 millimeter distance from the biceps tendon. So yeah, it can happen also much further, like 25 or much less, 3 in the anterior tendon, but then you know that this is the weakest zone. So looking at full thickness partial width tearing, we can see in this case that the tendon has been fully torn, but in transverse view, it's only a pinhole, and we can see that the tendon is still intact, and there's, in this case, not so much risk for retraction. So if you see this, this is a fully torn supraspinatus, a little bit retracted. We don't see any fibers connected. So on the Sonoskills pathology checklist, it scores positive on continuity, but also on echogenicity. There is an anechoic zone within the tendon. You still need to differentiate whether this is complete or full thickness partial width by looking in the other plane. Yes. Sometimes they can be very subtle. So in this case, there is also a tear. You can also see that the top of the bursa is not really convex, but there is a small concavity there. So it's also that in the depth, you can see this change in echogenicity, and this is a fully torn supraspinatus. And when producing a stress against abduction, you might see it that it opens up. And also, if you see these tearing, you might need to scan a little bit up and down to really see that this three-dimensional line is actually fully torn instead of partially. So you really need to follow this zone to from medial to lateral, proximal to distal, to really know the total extent of the tear. Okay, and a complete tear, grade 5. Then in both planes there is a full torn and cuff tendon, and in this case you can see exactly this image, transverse and longitudinal, and in both planes fully torn and a lot of fluid. And in time, a naked head sign might be developed. A naked head sign meaning on the humeral head there is no cuff anymore, and we can only see the bursa or the epimysium of the deltoid muscle on top of the humeral head. And in those cases, you can also see an increase of degeneration and change of the humeral head. And if a supraspinatus is fully torn and retracted, in many cases, in time, you see also a cranial migration of the humeral head. There is a loss of stability, so the acromiohumeral distance diminishes. Patients also complain about grinding because of this cranial migration of the humeral head. There is some friction between caput humeri, the humeral head, and the acromion. Hence also the cortical changes, and in very severe cases you can really see that instability is bound to happen, and also that even a pseudo joint is actually developing underneath the acromion. So yeah, this can happen. Fatty infiltration, we checked the rotator cable last week. This is the rotator cable. We also know that within the rotator cable, in this zone of footprint, this is relatively avascular. We know that it's at risk for tearing. And this is an interesting diagram or statistics, because we can see that the distance from the biceps, if there is 0 millimeters to the biceps, so in the anterior supraspinatus, this is the anterior supraspinatus, there is a high risk of degeneration, fatty infiltration. But if we are 10 millimeters, let's say 10 millimeters roughly in the posterior tendon, then there is a small risk of fatty degeneration. So what I always do is that if the tendon is torn, the anterior tendon, always check your supraspinatus muscle for fatty infiltration, because this is important to know whether it's still a functional muscle or qualitative muscle. This fatty degeneration you will see less in case of posterior tearing of the supraspinatus. So again, you can use different classification models. There is the Coutelier classification, but I use always this one, the Strobel classification. What we actually do is look at 2 points, 2 checks. If we're scanning the supraspinatus muscle, first, how is the echogenicity? Is the echogenicity the same as the overlying muscle? And in case of the supraspinatus tendon, the overlying muscle is actually the trapezius muscle. In case of the infraspinatus and teres minor, this is the deltoid muscle. So for all those 3 muscles, you can use actually this Strobel classification. So they should be similarly in echogenicity, but if there is fatty infiltration, you will see that it starts getting more hyperechoic, so a brighter hyperechoic white appearance. And then you can grade it slightly or markedly increase echogenicity. But also we know this interarchitectural tendon, this aponeurosis, this anterior cylindrical bundle within the anterior supraspinatus. Is it clearly visible with nicely, clearly, sharply depicted lines, or is it only partial visible or not visible at all? So let me show. This is normal. We see crispy lines of this internal aponeurosis. That's good. Both transverse and longitudinal. We can also see that the echogenicity of the trapezius and the supraspinatus are relatively the same. So this is also good. So this is a healthy supraspinatus. This is a little bit different. A hyperechoic zone starts to appear within the tendon, and it's really different from the overlying trapezius muscle. But also the aponeurosis is not clearly depicted anymore. So this is a Strobel stage 2. It's already starting with fatty degeneration. And this is a Strobel 3. This is a lot of fatty infiltration. It's very different than the overlying trapezius muscle, and we hardly see a aponeurosis within the tendon. And we also know from research this correlates quite well with MRI. So, and we know that this is important knowledge because if there is fatty infiltration within the rotator cuff muscles, it has a poor prognostic outcome for the success of surgery, meaning that a lot of surgeons, they won't operate if there is a lot of fatty infiltrations within the muscle. So it's a very poor prognostic outcome for cuff repair. And this is also proven in this article that 10 years after repair, if there was pre-operative fatty infiltration, then there was significantly associated with a greater incidence of re-tearing. So this is why you really want to know, is there any fatty infiltration? And this is mainly correlated to tearing of the anterior supraspinatus tendon. Right. Good. And if progressing in time, the fatty infiltration, this happens a lot with large cuff tearing that enlarge over time and have a larger magnitude of enlargement. So those are also poor prognostic factors on the fatty infiltration process. Good. So ending our supraspinatus pathology, do we have any questions? Which type of calcification is for aspiration? So I think that you're talking about the type 1, 2, or 3. So I would say that type 3 with no acoustic shade is easier to aspirate. The type 1 on the other side of the spectrum is the harder calcification with the acoustic shade. And to my knowledge, but I don't do any ultrasound guided procedures at the moment. I will start doing that in the near future. But that is more suitable for barbotage. So with the needle trying to break the calcification. So type 3, softer calcification, this is this toothpaste-like, and there is a certain possibility sometimes for aspiration. Good. So thank you for your question. Always nice to being interactive. I just want to highlight, we have a great course coming up. This is the hip webinar. Also a 3-part series about the hip. I was actually working on it today. It's going to start in a few weeks' time. And please, in your chat area now, you can see more information about that, or you go to Sonoskills.com, or probably you will receive a newsletter in the next weeks, or see some social media messages. But it's going to be a nice webinar about gluteal muscle problems, gluteal tendon problems, the whole trochanteric region. We will discuss inguinal hernias, femoral acetabular impingement, so all kinds of cool stuff. Hope to meet you there as well. Okay, so let's go back to the last presentation of today, and this is the part 3 presentation. Yes. Okay. So now we are going to discuss the posterior and inferior shoulder, and actually also the superior shoulder, because first we will start with the AC and SC joint. By the way, before I do this, I'm really enthusiastic. Once again, my favorite topic, shoulder and MSK ultrasound. So I might forget, so I'm going to do this right now. I'm going to share some articles with you. And these are 5 articles for you to study in this superior, posterior, and inferior shoulder region. You can download them right now in the chat area, or they will also be emailed to you probably at the end of this week. So if you don't receive an email tonight, tomorrow, or the day after tomorrow, don't worry, you will receive them before the weekend. But in this case, you can already, if you download them, you can already start reading and studying. Really nice articles. So first, the AC joint and SC joint. Looking at the AC joint, we have this ligament, this acromioclavicular ligament, which in fact is not really only a ligament, but is actually a capsule, a synovial capsule. And the AC joint is positioned right underneath fibers of the upper trapezius muscle. We know that the trapezius, or the AC joint, is quite narrow in the middle, and it widens if going to posterior or to anterior. So if you scan, compare left-right, you really want to know, are you measuring on the same level? Because otherwise you might think one joint is narrow, the other one is wide, but this might be because of the different position of the transducer. We know that the acromioclavicular ligament is actually also a synovial capsule. The AC joint is a synovial joint, meaning the definition of a synovial joint is 2 bones with cartilage in a capsule with synovial fluid, and sometimes even a extra feature, and this might be a disc. Like in the knee joint we have a meniscus, but in the same thing we also have in the AC joint. This also might be there might be a meniscus or a disc present. The AC joint is being supplied with nerves from the suprascapular nerve, meaning that if in the supraspinous notch problems occur, compression, this might also lead to pain distribution in this top of the shoulder in this AC joint area. And we always say the clavicula is a little bit higher compared to the acromion, but we also know that this can be different. Sometimes it's much higher, might be a trauma and problem of the coracoclavicular ligaments. It might also be normal anatomy. In this case, this pie chart explains that, for example, major protruding clavicle, 7.5% of the population has this normal anatomical variation. So, but I think that most people have a minor protruding clavicula, but please know that it's also possible to have a protruding acromion, minor or even major. And major is probably this 5% group, so that is a smaller group. And we have several types of clavicular or AC joints. There might be, yeah, there are several types, and this can also lead to the fact that in some cases you cannot look into the subacromial space, but in some cases you can actually look deep in the subacromial space. You can even see the distal capsule within of the AC joint within the subacromial space, and sometimes see even some fibers of the supraspinatus when the patient abducts his or her arm. We also know that the disc might be present, and it's very prone to degeneration, and I believe around the 4th decade, many cases this disc is absent or degenerated. How to measure like this: palpate the AC joint, place a transducer on top. Or what I always do is that when I'm scanning the supraspinatus and looking at the abduction, gliding of these of the supra and bursa within the subacromial space, if I do that, then the next transducer position I do is the AC joint, because I only have to slide on top of the acromion, and then I can already see it. So it's a very small step to the AC joint. And yes, in this case we can see air. This is bad for scanning, for the quality of the image. So you might put a lot of gel there, and you create a standoff, a gel standoff, and in that case you really hover the transducer in the gel above the skin, and then you have a perfect view on the AC joint. And this is what we see: the capsule and also clavicular acromion, the joint space width. In this case, we have this open type, so we can see the distal capsule of the AC joint, and this is the supraspinatus muscle. It's only sonoanatomy. You cannot judge or assess the supraspinatus, but it's there, and I just want you to know that if the patient abducts, then you can see these fibers going there. That's actually all. You can also place, instead of this approach, a more anterior approach. If we scan really on top of the shoulder, you can see this alignment, but when measuring more from the front, we can see this alignment, and that's sometimes also interesting to see, especially when looking or assessing certain Rockwood classification stages. So try this, try this, I would say. Petroons, Mr. Petroons, a radiologist from Belgium, I believe from Brussels, he published this cross-arm maneuver. The patient has her arm, in this case, on the quadriceps, and then ask the patient slowly to bring the hand to the other shoulder, and then slowly back again. And then it's really important to relax. Not too much muscle tension, but relax. And what we actually do is we scan the AC joint, and the AC joint needs to be stable. And if there's instability, you can see a large movement in this trajectory, especially at the end. If they go back and then relax, then you can really see this movement. So there can be a certain flexibility. That's okay. But it should definitely be not unstable. So that's important to know. Yes. So other dynamical assessments are possible. So in this research, what they did actually is measure the joint width of the AC joint. First, neutral, relaxed position. So please check. Yes, that's the joint width. And with horizontal adduction, the joint width narrows. So you have more compression of the AC joint. It's interesting for screening. Is it clinical relevant, my finding, yes or no? Can I really produce the pain the patient also has? But also to note, is there an instability? So this is interesting. Horizontal adduction against or horizontal abduction in an adducted position, so against applying a force against the assessor's hand, and then the joint space narrows even more. Or in this case, with the external rotation of the shoulder, and then we see a widening again of the AC joint. So looking at this, we can conclude that the middle picture actually produced the biggest stress on the AC joint, and you can use this to assess the AC joint on stability, but also on provocation. Personally, I first do this one. If the patient can handle it, then I'll do this as an extra, but I don't start immediately with this, because to do this, first you need to do this. So to me, this is a two-step approach. So those tests I just mentioned, those are actually about the checkpoint 5 of the Sonoskills pathology checklist. The functionality, right? So try to conclude or try to include clinical examination within your ultrasound guided assessment. Dynamical assessment of the shoulder while ultrasound guided assessment. I sent you an article about that, and you will receive this by email. So please read as much as you can dynamical scanning. The SC joint, of course, between manubrium and the manubrium and the clavicula, and then we can see that this also has a capsule. It's also synovial capsule, and it also has a disc. Placing the transducer like this, the central transducer tip a little bit distal and the lateral transducer tip a little bit proximal, so a little bit oblique. And this is what we see. This is the anterior sternoclavicular ligament, or the capsule, and we can see the disc, and we can see the bony partners of the joint. So looking at the AC joint and SC joint, according to the ESSR consensus statement, scoring a 2. So it's equivalent to other imaging techniques. And this is a sort of pathology of a unstable joint doing the cross-arm maneuver, right? And then we can see that within this maneuver, you can see that the joint space is getting more narrow, but also that the distance between the top of the acromion and the top of the clavicula is also getting smaller. So there is a shift of the clavicula and this movement. This is a clavicular resection. So the AC joint has been resected, and this allows us to beautifully also see the capsule in the depth. So you know that this capsule is indeed in the depth when looking in a quite an open AC joint. Well, this is a lot open because of the resection. This is a, you don't have to use ultrasound to see that there is a swelling here or a tumor. This is a geyser sign, and this geyser sign happens if there is a tear in the rotator cuff. Fluid collections might pop out the glenohumeral joint and go through the AC joint, and then suddenly we have this bulging. Actually, yesterday in the clinic, I had a patient, not as extreme as this one, but definitely a geyser sign. And then you can see the content within, and then you can decide, do I want to aspirate or do I want to do something else? So using a gel standoff, this is gel, the skin, and you can see that in this case, through the AC joint, we have this fluid going up. Yes, this is the clavicula, and so we scan the AC joint, we scan the SC joint, but you can also scan the clavicula. Well, the way I do it is first a superior approach, scan it, and then a inferior approach and scan it. So superior and inferior approach. And sometimes you can even see fractures. This is a fracture, or you can see some callus formation around the fracture. Yeah, so it could also be of help. And please know that if looking at the SC joint, then synovitis happens a lot. So expect thickening of the capsule, positive Doppler signal, but also erosions and osteophytes. This is really typical for the SC joint, especially in the rheumatology population or in the geriatric population. For example, like this, here we can see the SC joint, and in this case, the SC joint is highly positive with a severe Doppler signal. In this case, it's quite rare, but it's nice, and it might be a trick which you can use somewhere in the future if you would see that patient. This is a posterior location of subluxation or dislocation of the clavicle, and this is sometimes quite hard to assess on an X-ray. And in this case, we can see a clear step-off phenomenon. This is the sternum, this is the clavicle, and you saw in the pseudo-anatomical images, this should be much more aligned. So this is a posterior dislocation of the clavicle. Okay, so AC joint and SC joint. I just want to point out that we got some emails about the book I showed last time. This is our book or technical scanning book of the extremity joints. It's foundational level, and it shows the anatomical, or the transducer placement, the anatomical or the sonoanatomy, the anatomy description. It also gives you some norm values. It's 184 pages, costs 125 euros, including shipment. If you would like to order, send an email to info@sonoskills.com. And what I did actually is that if you go to the chat area, you can see the offer. But if you open it up, you can download 3 example pages, and the AC joint page is one of the example pages. So you could browse through, I believe, 4 transducer positions in this free sneak preview of the book. So hit the link, and then you can go there. We'll also make sure this ends up in the email you're going to receive with the articles and also your certification. Good. So do we have any questions? Raad Ali wants to know, what about PRP stem cells to treat partial tearing? So within Sonoskills, actually, we have a lot of trainers, 30 to 40 trainers, 35 trainers, and many of them have different expertise and specializations. And one of them is for example, Suresh Sudala, or Lorenzo Massi, Ezekiel Myland, Gonzalo Yamaguchi. Those are examples. And they know much more about PRP. They also do PRP courses within Sonoskills and PRP designated webinars. And I don't use PRP myself, so I would say I would refrain by answering this question because I might say something wrong. So we have a free webinar series and you can subscribe to this. It's absolutely free every Thursday from 5 to 5:30 Amsterdam Dutch time. And one of the upcoming webinars is actually the PRP. So please visit and ask this question over there. Right, so let's look at the infraspinatus and the teres minor. The infraspinatus and teres minor, they originate from the infraspinous fossa, and the spine, infraspinous fossa. So this is the infraspinatus, and in blue, actually, I don't have to highlight it, it's already there in blue. And this is the teres minor muscle. The infraspinatus originating from the medial margin of the scapula, going to the roughly the middle facet of the greater tubercle, but also we saw last time slightly the superior facet. And we've got the teres minor starting at the infraspinous fossa and also the lateral margin and going to the inferior tubercle of the greater tubercle. We know that the teres minor has actually two muscle bellies, or two bellies. We have a upper portion in yellow, we have a lower portion in red, and upper lower refers to the insertion actually on top of the greater tubercle. And we also know that these two muscle bellies, they have different nerve supply, so they really should be seen as two different muscle bellies. And here we can see the different muscle bellies of the teres minor, or the different nerve supply. One can be seen here and one can be seen here. So these are branches, for example, from the axillary nerve. The teres minor mainly acts in a external rotation if the shoulder is abducted. So, for example, the hornblower sign is one test also in this position, and it's really reliable to screen if suspected teres minor ruptures. This is the infraspinatus and the teres minor. So first look at the infraspinatus. Also, the infraspinatus has several parts. This is actually one part. This is one part. This is a second part, and this is a third part. And these parts also have different biomechanical functions. They have a different anatomical appearance, or sono-anatomical appearance. So this is important also to know when scanning. The upper part is mainly transverse, straight. It's not so well depicted in this case because you have to tilt the image a little bit. And the lower is more oblique. So when screening or scanning the infraspinatus, respect these fiber orientations. And now we know that at the green level, we can see in the green box. Yellow level, we can see inside the yellow box. And we know that also the infraspinatus has this long internal aponeurosis, which is quite absent in the teres minor. Think of this when deciding in sonoanatomy, am I actually scanning the infra or the teres minor? The internal aponeurosis is a clue that you're actually scanning the infraspinatus. Absence of the internal aponeurosis is a clue that you're scanning mostly the teres minor. And when scanning the infraspinatus, we also know that the subacromial subdeltoid bursa is superficial to it. And we also know that the infraspinatus has a nice connection with the glenohumeral capsule, but also with the posterior glenohumeral labrum. So when externally rotating and internally rotating, we can see the infraspinatus pulling on the glenohumeral capsule, but also pulling on the posterior labrum. Last time we discussed that the infraspinatus is not only on the middle facet, but is also on the superior facet of the greater tubercle, and not like the normal textbook images you can see on the left side. The right side's image B is more accurate, at least after Mokuzuki et al. In 2008. And like mentioned, the infraspinatus has this connection with the capsule, so they are intimately related. And this is what I mentioned about the different parts. We have this transverse part, we have an oblique part. So when scanning the fibers, infraspinous, right close to the infraspinous or the spine of the scapula, you need to have your transducer more horizontal. But once you go more to distal on the scapula, you increasingly need to turn it to oblique. And also, I would say, when scanning the tendon longitudinally, adopt a oblique position of the transducer, like that, and not too much like this, because this I see too much in courses. So this is more on top of the fiber alignment. Good. When scanning, like mentioned, oblique on top of the longitudinal infraspinatus, and this is what we see. This is the infraspinatus and the thickness, and then we can see the internal aponeurosis inside the infraspinatus, and in the depth we can see the glenohumeral labrum. And when sliding down, the transducer is a little bit more oblique, and then you will end up in the teres minor. So first what we do is we actually scan the infraspinatus with focus and the depth not so deep, high frequency. When having scanned the infraspinatus and also the bursa on top of the infraspinatus, we slide to posterior towards the scapula, and then we start scanning the labrum and the joint, the capsule. And when doing this, you need to change the settings, go deeper, lower your frequency to, and this is the first time in a whole shoulder joint that you need to lower your frequency. So please don't forget, and don't keep on scanning everything with superficial settings. So this is the difference between the infraspinatus and the teres minor. The infraspinatus has this aponeurosis. This is lacking in the teres minor. And please note that the transducer alignment is a little bit more horizontal / oblique. I would say more oblique, but even more oblique for the teres minor. So that's how you can differentiate it. In longitudinal perspective, in transverse perspective, it's even easier. You just follow let's do it like this. You just follow the spine of the scapula with the transducer orientated and transverse on top of the muscle. And when doing that, at one point, you will get really close to the human head, and then you can see the two separate muscle bellies of the infra versus the teres minor. And this is what we want to see: the glenoid cavity with the labrum. I mentioned last week or the week before about the luxation or subluxation of the human head, sometimes being missed. I mentioned also I saw it several times in various settings, by the way, not only in various settings. This is the height that it should be. So the human head, the top should be higher than the glenoid cavity, and this leads that the infraspinatus is oblique, a little bit anisotropy, and therefore also more hypoechoic. Good. So when scanning the infraspinatus and transverse, then we can see the spine of the scapula there. Placing the transducer on top of the spine of the scapula. If I tilt proximal, I end up in the supraspinatus. If I tilt to distal, I end up in the infraspinatus, and I can follow the muscle. And at one point, you can also see the infraspinatus or the teres minor muscle bellies. So it's not as clear as in this image. Mostly the infra is also much bigger, and the teres minor is much smaller. But while making external rotations, you can also see a different movement pattern. So that really, highlights the boundary between those two muscles. This is another point. Some people show their interest. I got some emails. Could you please highlight the quadrilateral space? Of course I can. But it's not as easy as it sounds because the quadrilateral space is very hard to image, or the interpretation of image is a little bit harder. The quadrilateral space is the boundary between the teres minor, the teres major, and the depth, and also the two triceps muscles. And within this quadrilateral space, there is a neurovascular bundle, the axillary nerve, but also a artery, and that can be impinged, and this can lead to complaints. This impingement can happen due to fibrous bands in the muscle, due to hypertrophy of muscle, due to swelling, muscle tearing, and then impinging can happen due to cysts. So trauma. So there is a variety of reasons why this could impinge. It is quite rare. And maybe it's not as rare as we think it is, because it's a lot of misdiagnosis, and it's not really easy to diagnose. There's not a true golden standard in this quadrilateral space. And if even there is, maybe the one that is closest to the golden standard is a injection to see if symptoms reduce if an injection is being placed in this quadrilateral space. But I will show you how to scan it. We know that this quadrilateral space is not only a gateway for this axillary nerve and also artery, but also some fibers of the axillary nerve, they blend into the teres minor muscle. So if teres minor muscles, if there are teres minor muscle problems, please also check the quadrilateral space. This is the muscle belly, the transverse muscle belly of the teres minor, and right next to it we can see a zone. If you switch on your Doppler, you can see the pulsation of the posterior circumflex humeral artery, with right next to it the nerve, the axillary nerve. And where do we place the transducer? We're going to place the transducer, let's say roughly here, on the boundary between teres minor and also the triceps muscles. And there we have this opening within the quadrilateral space with this neurovascular bundle popping out. So let's look at the sonopathology. First, the sonopathology, of course, of the infraspinatus. This is called the tadpole sign. This is a very nice article of Mr. Guerini. I think I also shared an article about that with you, about the infraspinatus. And the tadpole sign is like this little pre-frog animal, for all non-native English speakers, a tadpole. This is a tearing of the muscles of the infraspinatus with a certain retraction, and in MRI you can see that that this is the tadpole, And this is a typical sign for a large intramuscular tear with retraction of the infraspinatus. And this, you can see the staple sign in longitudinal. If I rotate the transducer to transverse, then the staple sign becomes this black eye sign. We can see this, the head of the tadpole in transverse with the muscles surrounding. In this case, we can see a large tear of the infraspinatus, but also with some hemorrhage around. This hemorrhage shows itself more hyperechoic. There is a loss of muscle fibers, and this is pretty hard to differentiate from fatty infiltration. So fatty infiltration also shows itself hyperechoic, like this hemorrhage. But in case of this hemorrhage, you would expect a large tear within the muscle, very close to the hemorrhage, and with a fatty infiltration, the muscle is infiltrated with fat tissue, but the tear is actually further down, more to lateral, near the tendon or in the tendon. A calcification with a faint shadow. So this is a type 2, almost a type 3. Now I would say a type 2 calcification, and it's producing a convexity. And then the question is this intrabursal or is it actually intratendinous? And in this case, it's intratendinous, following the bursa, and is actually on top of the calcification. So if the calcification is quite high in the tendon, then really check, is it intrabursal or is it still intratendinous? And this is a complete tear of the infraspinatus. We see a large anechoic zone. We see a hyperechoic zone. This is loss of fibril pattern. Why is this? There is a large tear, has been retracted, and this is the retracted stump of the infraspinatus with swelling really close by where the torn is actually, or the tear is actually happened. When looking at the labrum and infraspinatus, when asking the patient to externally and internally rotate, we can also see this posterior recess. So we have this inferior recess, of course, the axillary recess, but also we have a posterior recess. And sometimes you could see fluid popping up, this little balloon, which you don't see if the patient has his arm in this internal rotation. So this dynamical maneuver is really important. And by the way, this is the position how I place the patient when scanning the teres minor and infraspinatus. It's also being done in other ways, like this, for example, but I always do it like this, easy for the patient to hold on to the other shoulder. And if standing behind the patient, it's for me easy to maneuver the hand while performing the assessment. This is a Hill-Sachs lesion, can also be seen here. And yeah, you all know a Hill-Sachs lesion. When making this external, internal rotation, it's interesting to see whether, if this is the labrum, whether this Hill-Sachs lesion is going to hit the labrum. So sometimes you see that there is a interaction between Hill-Sachs lesion and labrum. In many cases, I don't think this is pretty exciting. Many people, I see this in many people, and most people don't have any complaints anymore. But if you do see this, you know that there was a luxation of the, or subluxation of the humeral head, and you do know that probably the labrum had a blow or a hit or a stretch, and maybe even probably a tear. So this also is food for your clinical reasoning. It's a piece of the puzzle. And this is what I mentioned about the dislocation of the humeral head. So in this case, you can see that it's normal, the distance between the top of the humeral head and the top of the glenoid cavity. And if there is a different position, suddenly these two align, and this should not happen. And typically you would see that suddenly this infra is becoming really bright. So that's the first thing you would notice. Wow, this infra is bright, it's very hyperechoic, it's not as dark as this. But this is horizontal, so we have perfect perpendicular scanning, very bright fibers. This is anisotropy, and it becomes quite dark. So yeah, so in this case, yeah, I always send the patient back to the doctor or for an X-ray. Yes, this is the labrum, and here we can see a detachment of, I think it's a detachment of the labrum, and some fluid underneath. This is the bare glenoid sign. The left image is symptomatic, the right image is asymptomatic. Look at the arrows, the white arrows. Image is not really perfect. I sent you 2 articles about that earlier. You will also get this per email. Yeah, this author really explains all the things that can go wrong with the labrum and how you can visualize it. I think you have to be careful. Ultrasound is not the golden solution for labral pathology, although in this article with relatively poor images, because they're not really bright, but still, I think that you can definitely see what the author is talking about. And this is the bare glenoid sign, meaning that on top of the glenoid cavity, we don't see the labrum anymore. It can be torn. This is the slit cap sign. The labrum is a little bit detached and slipping on, towards the humeral head within the joint, and that's called a slip cap sign. And you can see this on the left image. And this is the fragmented labrum sign. So the labrum is fragmented, so we see several parts of the labrum, and we know that then there is a pathology, and this is the fluid cleft sign within the labrum, the bright white labrum. You can see a cleft with fluid inside, so you see this anechoic zone within the labrum. Well, so be careful with this. Absence of signs in the posterior labrum doesn't say that there is nothing going wrong in the other parts of the labrum, because most parts of the labrum we cannot assess. So be careful with that. Good. So what does the ESSR say about quadrilateral space? Scoring a 1 on 3, so it's not so good. Suprascapular nerve entrapment in the sphenoid glenoid notch, you can see where the 2 is equivalent to other imaging techniques. And how does that look like? This sphenoid glenoid notch, so we can see the labrum, and when scanning the labrum and the glenoid notch, you only have to go a little bit more to posterior. There you can find the sphenoid glenoid notch, and there is this nerve, this suprascapular nerve, and also this artery with power Doppler. You can see that. And when you are making this external and internal rotation with the patient, you will see a vein becoming bigger with externally rotating, and with internally rotating becoming smaller again. And this is normal anatomy. So as long as you see this happening, this is normal. But does it stay dark, this vein or this anechoic zone? Although you are externally, internally rotating, in that case, it's pathology, and most likely it's a cyst near the suprascapular nerve, and it wasn't a vein. It could look like this. This is a cyst, and in this case, what they do is aspirate, and then suddenly you also see that this release pressure on the suprascapular nerve in the right image. And in this case, this is the suprascapular of the quadrilateral space. We can see the suprascapular nerve. Let me position this shortly here. And right next to the nerve, we can see a increased cross-sectional area of the artery. And in the right image, we can see that the artery is much smaller, but the nerve is also much smaller. So this is a compression of on top of the neurovascular bundle of the quadrilateral space. Good. Do we have any questions of the infraspinatus and teres minor? And in the meantime, I'll take a sip of water. No questions. Okay, so the last part, and then I guess that's in 15 minutes we're ready. Like I mentioned, that we would exceed the time with roughly 15 minutes. This is the axilla, and the axilla is being formed by the latissimus dorsi, the triceps and biceps muscles, and anteriorly the pectoralis major muscles. If looking at the axilla with ultrasound, the patient adopts this position, holds his own head. Sometimes this is a little bit difficult, so sometimes I'll keep the hand, the arm up, and then scan the patient's axilla. Or you can place the patient inside lying and do let gravity do the work. And actually, this is also an interesting region. We're going to look at the labrum, the humeral head, but also the axillary recess and the axillary pouch. And this is, in fact, the axillary pouch, a large capsular fold pouch that allows us to go up, to lift the arm, the stretch or the size, make sure that it doesn't stretch too soon and that we can really go up. We have range of motion. So placing the transducer like this, indicated with a red, then we can see the humeral shaft, we see the humeral head, we can see the capsule, clinohumeral capsule, and the axillary recess, and fluid collections can happen in this axillary recess over there. Overlying, we have the coracobrachialis muscle, or depending on where on the joint we are, it could be more latissimus or coracobrachialis. When scanning like this, we can, of course, scan, follow the curvature of the humeral head. And what we are going to assess is the distance from top of the capsule to the bone. We're going to assess the capsule thickness, how much fluid there is, not only on top of the humeral head, but also within the axillary recess. Many patients, they have troubles with abducting or elevating the arm. So you could also practice with a limited range of motion how to do it like that. That's a little bit more challenging. But if the patient is flexible, you can go up and even move the arm in several positions and do ultrasound guided assessment. Good. So the unaffected shoulder in this research, the distance from bone to top of the capsule was roughly 2.2 millimeters, let's say roughly around. Two affected shoulders was around 4.5. I would say anything below 3 is okay, and anything above 3 is not so okay. So those are the measurements. If you slide, if I'm scanning the axillary recess and I go with my transducer to distal, but to distal is actually to proximal because we're going from elbow towards the shoulder joint. So I'm going to proximal. I'm going over the humeral head And then on the other side, I can find the glenoid cavity with the inferior labrum. So, and then again, you can dynamically check also the labrum movement patterns if you do ultrasound-guided clinical assessment. Like this, patient lies in supine, and then you can maneuver the arm while scanning the labrum. And this is what you want to see. This is the glenoid cavity and the inferior labrum. This is a little bit smaller than the posterior labrum, and or has a little bit different morphology. And again, the way we look at the posterior labrum, we also look at the inferior labrum. So you want to have a triangle, hyperechoic, nicely, a nice volume, and while moving, this is a little bit flexible, but yet stable. So it should not really collapse or slip away to a certain place. And you can also measure the position of the humeral head in the glenoid cavity, sometimes with cranial migration. If the supraspinatus was fully torn, we saw that the acromiohumeral distance became smaller because of cranial migration of the humeral head. And then you can also see changes distally with this cranial migration. So, and we can also look at a transverse way to the glenoid or to the humeral head. And in that case, you really want to scan in this direction, the whole thing. You can see the thickness of the capsule, and we measure mainly bone to top of the capsule. When sliding the transducer more towards the muscle part, then we see the latissimus dorsi, but in the depth we can also see the subscapularis muscle. So this is, for example, the subscapularis. Here we can see the latissimus dorsi and the teres major muscle. So, and because of this reverse position of the arm, this is the deeper part of the subscapularis, and this is the more superior part of the proximal part of the subscapularis. Okay, let's look at the pathology. Left-right comparison, see the increase of distance from top of the capsule to bone compared to the other side. So measure, and this you can see with capsule problems, frozen shoulder problems. Although if a patient has a true frozen shoulder, it's very hard to reach this position to be able to scan it. With instabilities, you can also see it. Yes, so a relatively normal image, but in B, we can see an increase of thickness of the capsule. And this, like mentioned in frozen shoulders, you can see it like that. And this is the transverse image. This is the longitudinal image, both healthy and affected. And we can see this clear, change in capsule thickness, but also in echogenicity. So this is, the capsule thickening is more dominant in this case. And in this case, more dominant is the fluid. So the capsule actually looks pretty okay, but it's a real fluid problem. So filling of the glenohumeral joint. And in this case, we can see a proliferation of the capsule, fiber deposition slash proliferation, capsule thickening, and it's really diffuse echogenicity, and it's becoming more hyperechoic instead of the anechoic synovial fluid. And this article, by the way, written by Mr. Michelet in 2018, I also shared with you, so you can read all about it in this article. And here we can see this detachment of the labrum of inferior labrum from the glenoid cavity. And in this case, we can see that, remember supraspinatus fatty infiltration, this is subscapularis fatty infiltration. Like mentioned, this is the deeper part, this is the superficial part, but the superficial part has a total different fatty or echogenicity compared to the upper one, or to the deeper one. In this image, more superficial. Hyperechoic. So this is fatty infiltration of a part of the subscapularis muscle. So if a large subscapularis tendon tear is present, you would be able to scan like this and then look at the fatty infiltration of a large portion of the subscapularis muscle, which is relatively hard to scan in the anterior plane or anteriorly because of the position of the subscapularis between rib cage, the thorax, and the scapula. And in this case, we can see a latissimus dorsi muscle problem and strain. So if you would follow the latissimus dorsi towards the arm, then you see this not often, but I saw it a few times with some sports people in bodybuilding pressing weights. And in this case, it's also a muscle tear strain of the latissimus dorsi muscle, and we can see with some Doppler activity, some color Doppler activity in this strained area. Good. Do we have any questions about the axilla? I don't see any questions.